Epicondylopathy. Trauma causes major pain to the tendons. The epicondyle is a bony prominence at the end of the bone where tendons or ligaments attach. The lateral epicondylopathy or tennis elbow, irritation and overstretching of the extensor carpi radialis brevis tendon and forearm extensor muscles. This results in tissue degradation, loss of grip, strength, and pain. Medial epicondylopathy or golfer's elbow. Same forces, but it affects the forearm muscles that are responsible for forearm flexion and pronation, repetitive load-bearing activities, acute injuries that involve flexion, extension, pronation, or pronation of the elbow and forearm can lead to either lateral or medial elbow symptoms. Treatment is based on clinical history and physical exam, ultrasound, MRI. Treatment would be temporary immobilization of the joint with a sling, splint, or cast, analgesics, ice or heat, local injections of anesthetic, steroid, placement, rich plasma or combination, physical therapy. After the acute inflammation subsides. Rhabdo. So breakdown of muscle that causes release of intracellular contents, including the protein pigment myoglobin. And the myoglobin is what makes the urine dark. That is many times one of the first presenting symptoms, but it doesn't always have to be there, and it doesn't always mean rhabdo. The actual diagnosis of rhabdo is an increase in CK between 5 and 10 times the normal. When it gets to 15,000 on the CK, then you have to start worrying about acute kidney injury. So the myoglobin that's released into the bloodstream, it sort of gets sloshy and it blocks the tubules in the kidney, which causes a backup and decreases the filtering process. So physical interruptions in the sarcolemma membrane, they're the delta lesions. That is the route by where the myoglobin and other products go into the extracellular space, into the intracellular space or the bloodstream. Myoglobinuria is the presence of the myoglobin in the urine. So generally, it is by direct trauma or blunt trauma, burns, electrical injury, or excessive compression. Drugs such as alcohol, amphetamines, paralytic agents, anti-hyperlipidemic agents, antipsychotics, antidepressants, caffeine, cocaine, steroids, heroin, fibrinates, hypnotics, and sedatives, LSD, methadone, ecstasy, protease inhibitors. Also caused by excessive muscle contractions such as status epilepticus, delirium, acute cytosis, dystonia or strenuous activity or exercise, tetanus, infectious agents such as bacterial and fungal viruses, toxins, so carbon monoxide, venom from black widow spiders, Africanized honeybees, vipers, methanol, toluene, There is a hereditary enzyme disorder. They're rare but can cause it. And then other things such as diabetic ketoacidosis, electrolyte disorders, polymyositis, non-ketonic hypermolar coma, and endocrinopathy and heat stroke. So there's a classic triad with clinical manifestations. So you look for muscle pain, weakness, and dark urine. Those are your symptoms. Your urine, like I said, is abnormally dark because of the myoglobin. And it may be the first or only symptom, but again, not a reliable test for diagnosis. The reliable test is the CK. It only takes 200 grams of muscle to be damaged in order for the visible changes in urine. Now, the myoglobin is rapidly cleared and your levels return to normal within 24 hours. Creatinine and other enzymes are released in massive quantities, so you get intracellular proteins and enzymes. So this includes a loss of potassium, phosphate, nucleotide, creatinine, and creatine. Hypocalcemia is seen early, and then hypercalcemia is seen late. Now, your risk of renal failure increases with the increased levels of serum CK. So again, the most useful measure is the CK level, 5 to 10 times the upper limit of normal. And again, once the CK level exceeds 15,000, you worry about acute renal failure. You're also going to look at other lab tests, hyperkalemia. Of course, you worry about cardiac arrhythmias with that, a decreased BUN to creatinine ratio, and that is from the release of the creatinine from the damaged muscle. And so you want to make sure that you maintain urinary flow. You want to prevent kidney failure. You want rapid IV hydration to maintain adequate kidney perfusion. And hyperkalemia may require temporary hemodialysis. Osteomalacia. So osteomalacia is a metabolic disease. There's inadequate and delayed mineralization of osteoid in mature, compact, and spongy bone. The remodeling cycle proceeds normally through the osteoid formation. However, mineral calcification and deposition do not occur. But bone volume remains unchanged, but the replaced bone consists of soft osteoid instead of rigid bones. So then the bones are soft. There is vitamin D deficiency, which is a major risk factor, malabsorption of vitamin D, and then renal tubular disease, certain types of tumors, and disorders of the small bowel, hepatobiliary system, and pancreas. Those are causes of the vitamin D deficiency in the United States. Both vitamin D and calcium absorption are decreased, so vitamin D is lost in feces. Liver disease interferes with metabolism of vitamin D. It makes it so it doesn't go into its more active form. And then diseases of pancreas and biliary system cause deficiency of bile salts, and those are necessary for absorption in the intestines. So lots of ways that it causes a problem with vitamin D. So crystallization of minerals in osteoid requires concentration of calcium and phosphate. So when it's too low, that crystallization doesn't proceed normally, so you don't get normal ossification. The vitamin D deficiency, it disrupts mineralization because it normally regulates and enhances the absorption of calcium ions from the intestine. So when the concentration of phosphate in the bone decreases below a critical level, mineralization cannot proceed normally. Abnormalities occur in both spongy and compact bone. It becomes thinner, fewer, and irregular. Because the osteoid continues to be produced but not mineralized, abnormal amounts accumulate the coatings and the lining of the canals beneath the periosteum, and it leads to deformities in your long bones, spine, pelvis, and skull. So, clinical manifestations along with the deformities of the long bones, osteomalacia also causes diffuse muscular and skeletal pain, tenderness, particularly in the hips. It makes individuals hesitant to walk. Muscle weakness is common. You could have like a waddling gait because of it. You can have facial deformities, bow legs, knock knees, bone fractures, and vertebral collapse with minimal trauma. Low back pain is an early complaint, but it can also involve ribs, feet, and other areas of the vertebral column. Fragility fractures may occur. Uremia may be present. So your laboratory data is going to be BUN and creatinine levels, normal or low, serum calcium levels, serum inorganic phosphate levels are low, alkaline phosphatase and PTH levels are elevated. Radiography may show symmetric bowing deformities and fractures with callus formation. This is particularly in the lower extremities. This is known as pseudofractures. A bone biopsy obtains information on the bone structure, remodeling, and evaluates the presence of subclinical renal osteodystrophy. It determines bone architect turnover and aluminum deposit. So the treatment varies. General principles include the adjustment of serum calcium and phosphorus levels to normal, suppression of secondary hyperthyroidism, chelation of bone, aluminum if needed, administration of calcium carbonate, and this is to reduce administration. I don't know what you have that's to reduce. So administration of calcium carbonate, it says to reduce and then you sort of stop, but that's okay. Administration of vitamin D supplements, oral or infusion, and then biphosphonate and implementation of renal dialysis if needed. So then osteosarcoma. So this is the most malignant bone forming tumor. It's usually found in the bone marrow. Osteosarcoma occurs mostly in adolescents and young adults, generally younger than 20 years of age. It's higher in males than females. And then there's a secondary peak of osteosarcoma at about 60 years of age and older, especially with the history of radiation therapy. It's aggressive. It has a moth-eaten pattern of bone destruction. The borders of the tumors are distinct, and then they merge into adjacent normal bone. They contain solid osteoid and callus produced by anaplastic stromal cells, which are atypical, abnormal cells. They're not seen in normal developing bone. Many tumors are heterogeneous. So the osteoid is deposited as thick masses or streamers. These infiltrate the normal compact bone, they destroy it, and then replace it with masses of osteoid. The bone tissue never matures to compact bone, and most are found in the long bones, especially distal femoral around the knee area. The most common initial symptoms are pain and swelling. The pain is initially slight and intermittent, and then increases in severity and duration. It's usually worse at night and gradually requires medication. Trauma is often noted. Systemic chemotherapy and surgery are basically the treatments of choice with the location of the tumor and its size, grade, and pattern of metastasis, type, and extent of surgery. Perioperative chemotherapy has greatly increased the numbers of qualifying for limb salvage surgery, so that's important. And then there's some investigative agents, including monoclonal antibodies, hormone anti-antagonists, gene therapy, and then other biologic agents. Paget's disease, the second most common bone disease, and it is a state of increased metabolic activity in the bone. It's characterized by localized, abnormal, and excessive bone remodeling. Chronic accelerated remodeling, it eventually enlarges and softens the affected bones. This causes a bowing deformity, fracture, or a neurologic problem. It can occur in any bone, but most often it affects the vertebra, the skull, the sacrum, the sternum, the pelvis, and the femur. It's often symptomless. The diagnosis is often suspected when an elevated serum alkaline phosphate level or an abnormal X-ray is noted. So radioisotope bone scans, X-rays, and CT confirm the diagnosis. Serum plasma peptide is a serum marker that also may provide diagnosis. There's both genetic and environmental factors, including viruses, MOMS, I'm thinking maybe that's supposed to be mumps, influenza, and measles. So the pathophysiology, there's excessive reabsorption of spongy bone and the deposition of disorganized bone marrow is replaced by vascular fibrous tissue. The reabsorption phase of Paget's disease is followed by the formation of abnormal new bone at an accelerated rate. So the collagen fibers are disorganized and then glycoprotein levels in the matrix decrease. Mineralization may extend to the bone marrow. There's an increase in bone fragility and an increased risk for tumors. So the skull of normal remodeling is first evident in the frontal or occipital regions, and then it can encroach on the outer and inner surfaces of the entire skull, causing thickening, and it develops an asymmetrical shape. So this can compress areas of the brain. It produces altered mentation and dementia. This can also cause sensory abnormalities, impaired motor function. You can get deafness from the compression of the auditory nerve. You can have atrophy of the optic nerve and obstruction of the lacrimal duct. Headache is common. Extensive alterations of the facial bones are rare, except in the jaw, where sclerosis and thickening of the maxilla and the mandible cause displaced teeth and can produce a malocclusion. And then the femur can have an exaggerated lateral curvature in the tibia and anterior curvature, and stress fractures are also very common in lower extremities. So diagnosis is made on the basis of rad studies. Early disease is detected by bone scan that shows an uptake of bone radionucleotides. Plasma alkaline phosphatates and urinary levels are elevated. No treatment is needed if it's localized and it doesn't cause symptoms. Treatment during active disease is mainly for pain relief and then prevention of deformity or fracture. Biphosphonates are the treatment of choice, or a one-time infusion of zoldronic acid. This can provide long-term reduction of biochemical markers, even remission. Osteomyelitis. It's a bone infection, most often caused by bacteria. It can also be from fungi, parasites, and viruses. It's classified in different ways. The simplest is the mode of infection. So a bone infection is caused by pathogens carried through the bloodstream. It's called homogeneous osteomyelitis. Acute phase is often seen in children. It's characterized by fever, pain, and involuntary immobility of the affected limb. Contagious osteomyelitis occurs when infection spreads to an adjacent bone, and it's often caused by open fractures, penetrating wounds, surgical procedures, metabolic or vascular diseases, and there's lifestyle risks and advanced age are risk factors. So staph remains the primary microorganism responsible, and then others include group beta strep, H. influenza, salmonella, gram-negative bacteria, microbacterial, viral, and fungal infections. Those occur mostly in immunocompromised individuals. So cutaneous, sinus, ear, and dental infections are the primary sources of bacteria. Soft tissue infection, disorders of the GI tract, infections of the GU system, and respiratory infections are also bacterial sources. So regardless of the source of the pathologic features, first, the invading pathogen provokes the inflammatory response, produces toxins that destroy the neutrophils, and then forms colonies of microorganisms. Those are biofilms. They adhere to the surface and increase antibiotic resistance. Biofilms can reduce the duration of osteoblast activity and enhance the osteoclast activity and promote inflammation. So primarily through the activation of the cytokine pathway, the biofilm and inflammation alter the normal balance between osteoblast and osteoclast activity. Once inflammation starts, the small terminal vessels thrombose and exudate extends into the metaphyse and the marrow cavity and through the small metaphysical openings in the cortex. Blood vessels that enter the bone are disrupted and deprive underlying bone of blood supply, leading to necrosis and death. Osteoblasts lay down new bone, partially or completely surrounding the infected bone, called involucrum. Openings allow exudate to escape into the surrounding tissue, ultimately through the skin by way of the sinus tracts. So clinical manifestations, depending on the age of the individual, site of involvement and initiating event, the affecting organism, and the type of infection, whether it's subacute, acute, or chronic. It's generally considered acute if it's diagnosed within 2 weeks after symptom onset and an abrupt onset of inflammation. Subacute if it's present for 1 to several months, and then chronic if it's been many months, even years. If an acute infection is not completely eliminated, then it can become subacute or chronic. Subacute symptoms are usually vague. Chronic stage infection is silent between exacerbations, and then your symptoms can include fever, malaise, anorexia, weight loss, and pain in and around the affected area. Edema may or may not be present. Recurrent infections in the urinary, respiratory, and cutaneous or instrumentation, such as catheterization, cystoscopy, usually precedes the onset of symptoms. Single or multiple abscesses, known as Brody abscesses, are characterized. Subacute or chronic stages. Brody abscesses are circumscribed lesions 1 to 4 centimeters in diameter, found at the ends of long bones and surrounded by dense bone matrix, and thought to develop when infectious microorganisms, disease, or the individual's immune system is resisting the infection. So evaluation and treatment, lab data, so elevated WBCs and elevated non-cardiac C-reactive protein, or your CRP, RAD studies, so bone scanning, CT, functional imaging, SPECT imaging, highly sensitive for evaluating the extremities. So your treatments are going to be bone biopsy to identify the organism, use of antimicrobial agents, debridement of infected bone, biodegradable antibiotic impregnated bioabsorbable beads are beneficial, injectable scaffolds impregnated with antibiotics and other antimicrobial substances, surgical removal of the inflammatory exudate, wound irrigation with antibiotic solutions, hyperbaric oxygen therapy that can help stimulate healing, and if it's a joint, then a total replacement with implants. Osteoporosis, a decreased bone mineral disease and an increased risk of fractures because of alterations in the bone. The microarchitecture is often silent for decades until fractures occur, and it is the most common disease that affects but is not part of the aging process. So old bone is reabsorbed faster than new bone is being formed, and it causes the bones to lose density. They become thinner, more porous, and this continues until the skeleton is no longer strong enough to support itself, and it can spontaneously fracture. Most common sites are related to the spine, femoral neck, and the wrist. Factors that can affect bone homeostasis include steroids, PPI, SSRIs, anticoagulants, vitamin D deficiency, underlying diseases such as rheumatoid disease, cancer, diabetes, low physical activity, and then an abnormal body mass index. Postmenopausal osteoporosis is bone loss that occurs in middle age and older women due to an estrogen deficiency, as well as from estrogen-independent age-related mechanisms. Deficiency can also increase with stress, excessive exercise, and low body weight, and it can result in a substantial increase in bone turnover. So the pathophysiology, it develops when the remodeling cycle or coupling, bone absorption and bone formation is disrupted. This leads to an imbalance in the coupling process. Osteoclasts are differentiated cells. They function to reabsorb bone. Glucocorticoid-induced osteoporosis is the most common type of secondary osteoporosis. It has a direct impact on bone quality by improving osteoclast survival, inhibiting osteoblast formation, and function in increasing osteocyte apoptosis. Age-related bone loss begins in the 3rd to 4th decade and is known to decrease serum growth hormone levels along with increased binding of ANKL and decreased OPG production affect osteoblast and osteoclast function. So clinical manifestations depend on which bones are involved. The most common are pain and bone deformity because of fracture that occur in advanced disease states. As the bone loses volume, they become brittle and weak, and they can collapse or they become misshapen. Vertebral collapse causes kyphosis, that's the hunchback, and it diminishes height. Fractures of the long bones, particularly the femur, distal radius, ribs, and vertebra. Most common fatal complications Fractures include fat or pulmonary embolism, pneumonia, hemorrhage, and shock. So we need an adequate dietary intake of calcium, vitamin D, magnesium, and other trace minerals, adherence to a regular regimen of weight-bearing exercise, avoiding alcohol, tobacco, and steroids as well. It's diagnosed by radiographic images, x-ray. That's the gold standard for detecting. It's x-ray absorptiometry, and it's the gold standard for detecting and monitoring osteoporosis. Newer MRIs, can be helpful. Serum and urine biomarkers, that's used to monitor the bone turnover. The goal of treatment is to reduce the risk and prevention of fractures. Biophosphates are first-line medications for treating osteoporosis. They inhibit hydroxyapatite breakdown, which reducing bone reabsorption. The anabolic or bone-building drug parathyroid hormone, PTH, is a major regulatory of chemical homeostasis and acts directly on osteocytes. It stimulates bone formation and promotes the migration of progenitor bone cells from the marrow into the bloodstream, increasing the production of osteoblasts when intermittently administered. Degenerative joint disease, treatment recommendations are anti-inflammatory medications, PT, lifestyle changes, change your activities, lose weight. Braces or orthotics have also been helpful. And, early start to treatment can slow progression. Rheumatoid arthritis. So this is a chronic systemic and inflammatory autoimmune disease. Joint swelling, tenderness, destruction of synovial joints. It leads to disability. Most common joints are fingers, feet, wrists, elbows, ankles, knees, shoulders, hips, and cervical spine, as well as tissue of lungs, heart, kidney, and skin. So it increases with age. Of course, inflammation, destruction of joints, but it can also cause fever, malaise, rash, lymph node or spleen enlargement, and Raynaud's phenomenon. The pathophysiology, trauma, illness, and environmental conditions have been identified. During inflammation, alpha amino acid protein arginine, it's modified into citrulline, so they can be seen as antigens by the body's immune system, causing T and B cells to play a role in that autoimmune response, promotes osteoclast formation, and causes bony erosion. Cartilage damage results in 3 phases. Neutrophils and other cells in the synovial fluid become activated, which degrades the surface layer of the cartilage. And then 2 inflammatory cytokines induce the breakdown of cartilage and bone. And then 3, the T cells interact with synovial fibroblasts, converting synovium into a thick abnormal layer of granulation tissue. This is known as a pannus. Inflammatory and immune processes have damaging effects on the synovial membrane, and there's swelling from leukocyte infiltration in the membrane. There's a hyperplastic thickening as the cells proliferate and abnormally enlarge, involving blood vessels. Those vessels become occluded, by epithelial cells, fibrin, platelets, and inflammatory cells. So it decreases the vascular flow to the synovial tissue. So you get compromised circulation coupled with increased metabolic need, resulting from hypertrophy and hyperplasia. It causes hypoxia and metabolic acidosis. So clinical manifestations, general manifestations of inflammation, including fever, fatigue, weakness, anorexia, weight loss, gradual achiness and stiffness. Joints become painful, tender, and stiff, and pain is associated with pressure from swelling right in early stages and new bone formation in the late stages. Joints lose mobility and can lead to reduced range of motion after an inflammation subsides. It can progress to permanent deformities, fingers, toes, limbs. Rheumatoid nodules are most common extra-articular manifestation, and it's a collection of inflammatory cells surrounded by a central core fibrin and cellular debris. It's found in subcutaneous tissue on the surface of elbows and fingers. Diffuse pulmonary fibrosis may occur because of a mediated immune complex. Disposition nodes on the valve can cause deformities, especially in the aortic valve, leaflets, and pericarditis. Can also cause splenomegaly, acute and fasciitis, thrombosis, MICVA. Evaluation and treatment. So early treatment is effective in preventing systemic joint abnormalities or chronic disease. Autoantibodies, RF and protein in your body can be present for years. ACPA is a much more significant marker for RA. Clinical exam and history are the mainstays for diagnosis. Early treatment begins with disease-modifying anti-rheumatic drugs such as methotrexate, cyclosporin, that slows progression and may prevent complications such as joint deformities. Methotrexate is the first line of treatment, and it's aimed at interrupting the pathogenesis of the disease. Education for individuals is fundamental to treatment. Other treatments include NSAID, steroids, steroid injections, physical and occupational therapy, therapeutic exercise, and use of assistive devices. Surgery is used to treat deformities. Fibromyalgia. So it's a chronic musculoskeletal syndrome characterized by diffuse joint and muscle pain, fatigue, increased sensitivity to touch. There's tender points. The absence of systemic or localized inflammation in the process of fatigue and non-restorative sleep, anxiety, and depression are also common. Patients may report tenderness in all body regions and increased sensitivity to numerous stimuli, including heat, cold, and electrical, as well as sensitivity to light and sound. Pathophysiology, it's sort of unclear, possibly some genetic factors, external stressors such as infection, psychosocial stress, and physical emotional trauma. MRI, PET scans, those have actually shown activity in the areas of the brain that are different from those seen in healthy individuals when exposed to painful stimuli. So clinical manifestations, fatigue, sleep disturbances, cognitive problems, memory, headache, dizziness, pain in the muscles, skin, problems, joint pain, morning stiffness, restless leg syndrome, urinary problems, dysmenorrhea, nausea, tender joints, jaw pain, and problems with vision. Differential disorders must be eliminated and also meet criteria of symptoms. Symptoms should be present for at least 3 months. Individual doesn't have a disorder that would otherwise explain the pain. Treatment is highly individualized. It can include mind-body interventions as well as biofeedback, movement therapies, and relaxation technique as well as medication. No one regimen or medication has proved successful, and current recommendations include pharmacological and non-pharmacological combinations. Gout. Gout is an inflammatory response to excess quantities of uric acid in the blood and body fluids, including synovial fluid. This leads to the formation of monosodium urate crystals in and around the joint. It becomes painful and inflamed. Small white nodules are visible through the skin, and they're associated with joint damage. An increased death rate, primarily because of cardiovascular events associated with hypertension, heart disease, type 2 diabetes, kidney disease, and metabolic syndrome. Hyperuricemia is essential, but it's not the only factor. Others include age before 30 years, genetic predisposition, excessive alcohol consumption, obesity, certain drugs like thiazide, and then also lead toxicity, dietary intake of purine-rich foods such as organ meats, pork, fish, and beer. Foods high in fructose and sugar, so sweet and soft drinks, as well as dairy products, coffee, vitamin C, have shown to have protection against gout. The pathophysiology, so purine metabolism and kidney function at the cellular level. Purines are synthesized into purine nucleotides, which are synthesized into nucleic acids, ATP and CAMP. Uric acid is a breakdown product of purine nucleotides. So primary gout are those with unknown metabolic defect, and secondary gout is when etiology is unknown. So uric acid is eliminated through the kidneys, and it undergoes reabsorption and excretion within the tubules. Primary gout urate excretion is sluggish, and it results in a decrease in glomerular filtration and an acceleration of reabsorption. The crystals are deposited in renal tubules and can cause acute neuropathy or nephropathy. So clinical manifestations. So first, there's an increase in serum urine concentration or hyperuricemia. And then recurrent attacks of arthritis, inflammation of a single joint. There's a deposit of MSUs in and around the joints. Renal disease involving glomerular, tubular, and interstitial tissues and blood vessels. The formation of renal stones. These manifestations appear in 3 clinical stages. So first is asymptomatic. So that's hyperuricemia, where the urate level is elevated. There are arthritic symptoms. Tophi and renal stones are not present. So this stage may persist throughout life. Acute gouty arthritis. So attacks develop with an increased serum urate concentration, and they occur with sudden or sustained increases of hyperuricemia, but can also be triggered by trauma, drugs, alcohol. And then 3 is tophaceous. It's the chronic stage of the disease, and it can begin as early as 3 years or as late as 40 years after the initial attack of gouty arthritis. Progressive inability to excrete the uric acid. It expands the urine pool until MSU crystal deposits appear in cartilage, synovial membranes, tendons, and soft tissue. So, trauma is the most common aggravating factor of acute gouty exacerbation. Initial attack is usually in the great toe, known as espadagra. The pain is usually noted at night, and within a few hours, the affected joint becomes hot, red, extremely tender, and maybe slightly swollen. Leukocytosis, fever, and elevated SED rate are occasionally present. Untreated mild attacks usually subside in several hours, but may persist for 1 or 2 days. Severe attacks may persist for several days to weeks. Renal stones are 1,000 times more prevalent with primary gout and may be the size of a grain of sand or a piece of gravel. So diagnosis is made from history and physical exam. It may include blood tests, possible joint aspiration, use of diagnostic imaging. The goals of treatment are to terminate the acute gouty attack as promptly as possible, reduce the uric acid levels, avoid recurring attacks, prevent or reverse complications associated with urate deposits in the joint, soft tissues and kidney, and to prevent the formation of kidney stones. Numerous drugs are used to prevent or abort attacks of arthritis. Non-pharmacological treatments include application of ice for pain relief and inflammation of the joint. Weight bearing on the involved joint is avoided until the acute attack subsides. Reducing body weight, avoiding alcohol, and changing dietary practice may reduce recurrent gouty episodes. Fractures. Healing of fractures. Direct primary healing, intramembranous bone formation. It occurs when adjacent bone is in contact with one another, such as when surgical fixation devices are used. There's no callus formation. Occurs with direct bone healing. Indirect or secondary healing involves both intramembranous and endochondral bone formation. There's a development of callus and eventually remodeling of solid bone. Bone formation that begins with underlying cartilage scaffold is termed endochondral bone formation. Non-union is where an improper reduction or immobilization of a fractured bone may result. Non-union is a failure of the bone ends to grow together. The gap between the broken ends of the bones is filled with dense, fibrous, and fibrocartilaginous tissue instead of new bone. Occasionally, the fibrous tissue contains a fluid-filled space that resembles a joint, and it's termed a false joint or pseudoarthrosis. Dislocation is usually caused by trauma, and it's the dislocation of one or more bones in a joint in which the opposing joint surfaces entirely lose contact with one another. Subluxation is usually caused by trauma as well, and it's when the contact between the opposing joint surfaces in one only partially lost or partially dislocated. A stress fracture can acquire a normal or abnormal bone. The forces placed on the bone are cumulative and eventually cause a fracture, occurring during activities that subject the bone to repeated sprains, such as certain types of sports. A greenstick fracture, it perforates one cortex and splinters the spongy bone. The name is derived from the damage sustained by a young tree branch when it's bent sharply. The outer surface is disrupted, but the inner surface remains intact. These fractures typically occur at metaphysis or diaphysis of the tibia, radius, and ulna. Pathologic fractures are also known as insufficiency or fragility. It's a break at the site of a pre-existing abnormality resulting from force that would not normally fracture a bone. And any bone that lacks normal ability to deform and recover, these fractures can occur with normal weight bearing or activity. RA, osteoporosis, Paget's disease, osteomalacia, rickets, hyperparathyroidism, radiation therapy, all of those things can cause the bone to lose its normal ability to deform and recover. These generally are a result of bone weakness caused by another disease such as cancer, metabolic bone disorders, or infection. Breaks in the bone attribute to osteoporosis and can be referred to as pathologic fractures. Transchondral fractures consist of fragmentation and separation of a portion of the articular cartilage. Single or multiple sites may be fractured, and the fragments may consist of cartilage alone or cartilage and bone. Typical sites of these are distal femur, the ankle, the patella, the elbow, wrist, and most prevalent fractures in adolescence.